Good afternoon and welcome to all the people who've registered and turned up today for today's, what is the third in our series of mental health thematic ecosystems. My name's Andy Bleeden, I work for the European Connected Health Alliance. We're building a series of these thematic ecosystems, which today is targeting the area of substance misuse. As you see, we've got a large panel gathered here today from across Europe, including speakers from Germany, Portugal, Luxembourg and Denmark. What we do with these thematic ecosystems, for those people who've not been to them before, this is a great way to showcase our philosophy around ecosystems, which is showcasing both need and solution. So we're going to hear from some programs around addiction prevention in Germany. We're going to see what the need is in Portugal. We're also going to see what some good practice examples are from both Denmark and Luxembourg, but also see some really good examples from Germany about how we use counselling services and apps around the field of substance misuse. Then hopefully we'll have some time, if people keep to their tasks, to do a discussion. But before we move on, let's just talk a little bit about what I mean by the word ecosystem and the thematic ecosystem to start off with. We at the European Connected Health Alliance have devised and developed and built a network now of over 70 geographical ecosystems based across the globe, all the way from Argentina to Australia. Many of those are in Europe, and certainly in the last couple of years we've seen a rise in the levels of collaboration between our ecosystems as the ability to be able to collaborate online has taken place. What our ecosystems are permanent multi-stakeholder gatherings, bring together all the stakeholders that you can see in the top right of your picture there. Primarily, and most importantly, they're led with a need. The idea is that then our ecosystems collaborate together in what we've developed to be, during the pandemic times, a series of thematic ecosystems. These are led by and built with our ecosystems, of which Rhineland Bond's one of them. We have them in Denmark and in Portugal as well. We hope to have one soon in Luxembourg. But we have built these with our ecosystems to deliver a series of subtopics on the subjects you can see in front of you. So on the topic of mental health, we've already covered the subtopics of adolescent mental health, working with younger people and mental health problems, specifically, and not just within the pandemic. But also we've covered topics such as isolation. And today we're diving down deep in the issue of substance misuse and its impact in terms of mental health provision. The rest of our thematic ecosystems are all on the topics you can see in front of you. I'll put a link in the chat function for you to register to any of these. They're all free to attend, just like today. And the idea is about showcasing need and solution. Let's talk about the need a little bit. My background over the last 30 years has been in health and social care, specifically around the field of mental health and dementia. When I started work many years ago in the field of mental health, it was with mentally disordered offenders in the UK. And a large problem there was management of people's health and well-being, combated to the substances they were using at the time and self-medicating, and the impact that had on both their well-being and those around them. Let's clarify what I mean by substance misuse. That's misuse of alcohol, chemicals, street drugs, prescription drugs, and any other illicits that might be around on the market. My involvement within the psychiatric field has taught me a great deal about the conflicting needs of providing decent services for people on a judgment-free basis. What I've also learned as a professional is that can be tested when people choose or make choices around self-medication, or indeed to change their lifestyle using different substances. The impact for healthcare professionals can be alarming, because very often that then removes the service we provide for those people. So in some countries, we know that we occupy and fill the void for housing people with mental health problems until they start drinking or using drugs. And then we lose them because they're no longer welcome in our establishments, or our services are withdrawn because their behaviour may become challenging. The impact on families and carers is another topic that's worth discussion, which again is why we're looking at both need and solution today. But what we want to try and do today is look at across Europe. This is a common issue. This isn't focused just on the UK or Germany or Ireland. This is a common issue across Europe, and we think globally. So I'm going to introduce some speakers today. I think we've got an exciting panel for us today. I'm not going to talk any longer. I'll put some details in about us if you want to find out more about the ECH Alliance. As I said, we're a member organisation. It's free to join if you're a not-for-profit or a public body. But enough about that. Let's move on and listen to our first speaker. Can I have the next slide, please? So I'm pleased to introduce Maria Friedrich. Please, if you could share your screen.
Great, and so while Maria will be sharing her screen, so my name is Alexia Zukuln. We are teaming up with the European Connected Health Alliance in terms of this thematic ecosystem on mental health, and so we've been all working together in assembling today's agenda, and we're more than thrilled to have the Federal Centre for Health Education on board. Maria kindly agreed to give us a keynote speech on addiction prevention in Germany, and maybe fill you in on the way things are done here, and I'm sure she will tell you more about the Federal Centre for Health Education and about herself and her focal points on substance misuse and addiction prevention. So thank you very much for being with us this afternoon. It's a great pleasure welcoming you.
So, thanks for the invitation and the opportunity to present here at ECH Alliance. So, my name is Maria Friedrich. I'm Scientific Officer at the Federal Center for Health Education, based here in Cologne, Germany. So, this is my today's agenda. First, I will give you an overview of the importance of addiction prevention in general, and second, of ways for addressing target groups. First, let's start with the relevance of the topic. Andy just said it before in the introduction. So here in Germany, every year an estimated 127,000 people in Germany die prematurely as a consequence of smoking. Around 74,000 die as a consequence of harmful alcohol consumption or by the combined consumption of tobacco and alcohol, while last year or the past years in 2020 are roughly 1,600 deaths resulted from the abuse of illicit drugs. Regarding behavioral addictions, nearly 230,000 people exhibit problematic gambling behavior. And also, in addition, the overall economic costs of harmful alcohol consumption are estimated at 57 billion and of smoking at 97 billion a year. By the way, all the sources are on the last slide on my presentation. So the primary objective of addiction prevention is to promote the health of every individual. This includes avoiding or delaying the first use of legal and illicit drugs, identifying and intervening in high-risk behavior early on, as well as the reducing abuse and addiction. First of all, modern addiction prevention systematically reaches target groups in their living environments and strives to effect health-promoting changes in knowledge, attitudes, and behavior. A primarily salutogenic approach is used, for example, empowering of resources and in particular life skills and risk competences. So in Germany, or at least in the German approach, addiction prevention is separated in 3 categories. Universal prevention activities form the mainstay of addiction prevention. For example, in 2019, nearly 66% of the documented activities in Germany had a universal prevention approach. The base is 25,000. Also, universal prevention activities are aimed at the general population, irrespective of their risk profile regarding the development of substance abuse behavior. And the activities are usually provided in the everyday life and living environments of the target groups, and usually take place in settings such as school, leisure, work, municipality, or sports clubs. On the other hand, selective prevention is aimed at groups of people who have an increased risk of developing a substance dependence, mostly without having exhibited it. So the target groups are often approached in recreational settings, for example, children for families with addiction problems, or music and party settings, or, for example, pregnant substance users. And the focus of indicated prevention is the identification of vulnerable people to counteract individual risk factors to support this group's personalities development as early as possible. The other pillar is the environmental prevention. So statutory regulation and restrictions on sales and advertising are applied. So these interventions aim to change the cultural, social, physical, and economic conditions that lead to or promote the emergence and development of diseases. So here, the intention is to influence the use behavior of individuals by limiting the availability of consumption opportunities. And examples are, for example, the German Youth Protection Act, the Alcohol and Tobacco Tax Regulations, and the German Narcotic Drugs Act. The foundation of the national drugs policy in Germany has 4 levels. As you can see, the prevention being a central component. So the German federal government, the individual federal states, also called Länder, and the municipalities share the responsibility for drug and addiction policy in Germany. According to the German constitution, the federal government has legislative competence for narcotic drug laws, criminal law, and social welfare law. And here within, the Federal Center for Health Education is a specialist authority within the portfolio at the Federal Ministry of Health. The Federal Center for Health Education, now I go on with BZGA, is responsible, among other things, for the implementation of national programs for addiction prevention at the federal level, for planning and executing prevention campaigns, as well as monitoring addiction prevention activities and their quality assurance. Basically, the addiction prevention of the BZGA focuses on universal approaches to alcohol prevention, tobacco prevention, early addiction prevention, life skills, etc. in childhood, prevention of the use of illicit substances, and behavioral addiction prevention, here with a focus on gambling and excessive media use. The priority target groups are adolescents, young adults, as well as adult caregivers of children and young adolescents, for example, parents, trainers in sports clubs, and so on. Sub-target groups, such as pregnant women, parents-to-be, or older people, are addressed individually. And other important target groups are multipliers or disseminators, such as addiction prevention specialists or medical professionals. The BZGA's prevention programs follow a multi-level campaign strategy that includes mass media efforts, direct communications, and internet presence, as well as linking relevant communication channels to respective target groups to achieve an optimal synergy. To reach broad sections of the population, mass media efforts such as posters, print advertisements, cinema and TV commercials, as well as print media are employed. And because within the multi-level campaign strategy, they form the basis for creating the attention for a health topic in the population. Unfortunately, I forgot to put a picture here, but if you have any question, I can give you later. For more depth information and suggestions for self-reflection or behavioral change are provided in the campaign strategy via personal communication and digital information services. Of growing importance in the campaign strategy is digital communication. So regarding addiction prevention, the BZGA offers topic and target group specific web portals that include scientifically based, constantly updated information and interactive offerings to promote self-reflection. And also such offerings are extended by evaluated online behavior change programs that provide, for example, support in reducing consumption. And the web portals are linked to special social media channels on YouTube, Instagram, Twitter, and Facebook. So these activities of the campaigns serve in particular to create and further dialogue and community building, as well as to promote web portals where in-depth information can be found. So here I'm going to show you 3 examples. For example, the first one is a self-test regarding to gambling. The second one is an online behavior change program. It's Quit Shit for reducing cannabis. And the other one is the Instagram channel of our alcohol campaign. And 2 other areas are of great importance. For many decades, the BZGA has conducted regular representative surveys on the consumption behavior of adolescents and young adults. They provide the scientific data on which the specific prevention programs of the BZGA are based and adapted, and it shows trends in knowledge, attitudes, and consumption behavior. And also cooperation is longstanding and very well linked to the coordinators for addiction preventions in the federal states, as well as with the German Central Office for Addiction Issues. So this cooperation also represents the networking of offers of addiction prevention and addiction support. And in addition, the cooperation circle is committed to the continuous further development of quality and evidence-based addiction prevention. And last but not least, of course, the corona pandemic has had an impact on the addiction prevention activities of the BZGA. So worthy of mention is the thematic intermeshing or integration in the context of corona and the changing need for advice in terms of content, mostly by telephone and online. So the contact restriction during the lockdown caused by the corona pandemic and the new framework conditions for personal interaction have also changed addiction prevention. So interactive prevention offers in school have been suspended, as have support for preventive activities in sports clubs or the implementation of peer programs. And on the other hand, the use of digital venues, both in the implementation of addiction prevention offers and in cooperation of networking with the federal states has become a new focus. So in the end, let's say, so the corona crisis thus can also become an opportunity for more digitization in addiction prevention. And I'm glad to hear later the colleagues of Blue Prevent who can maybe show some practical advice. Thank you. I show you some links for further information, and these are my sources. If you have any questions, let me know.
Thank you very much, Maria. I'm taking the opportunity that no one is raising her or his hands as of now. In regards of, because I know that later in today's webinar we'll be looking at the apps and so on. Do you have like a rough estimate of the use of or the number of followers on Instagram, for example, and the reactions that you get on the campaigns on that channel?
Not at all. I think here, what I hear, they're like nearly 4,000 followers. It's just a campaign for the adults of the campaign. The other one, I don't know, because I have I have other topics.
But so, and so
that's not mine.
The strategy, as you've highlighted there, is that so you've got different campaigns depending on different substances.
Yes.
And so you would have the example on Instagram, so 4,000 for the alcohol misuse. Okay, yeah, that's great. For anyone not living in Germany, that's actually quite it's a very visible campaign because it was used on a number of media channels. So that's why I was interested in particular on the response that was generated on Instagram, because you had the classical bus stop, but you also had TV campaigns. Obviously also flyers that were sent to schools, I believe, and the Instagram channel. So it was.
That's what I just said. I just forgot to put some bigger pictures of the mass media products, but I can give it later for the presentation.
Well, thank you very much for this introduction to the German way of addressing prevention. Now, I'm also delighted to have Adriano on board. Adriano is basically, I mean, you are so many things. It's always very difficult to introduce you. But you are the Innovation Director of Santa Casa de Misericordia de Amadora, which is also a reference, an EIP on AHA reference site for those of you who still know EIP on AHA. That was the European Innovation Partnership on Active and Healthy Aging. And you're very active on the European exchange level of regional solutions and way of addressing societal challenges. And so I'm very delighted to hear you talk today about, basically you are going to be bridging us. You're going to take us from a description of the needs and also start discussing the way you've been approaching things in your region. So thank you very much for joining. Can't wait to hear you tell us more about that.
Thank you very much, Alexia and Natalie, for the kind invitation. It's a privilege to be here with this panel of experts. So I will, exactly as you said, I will share my experience in Amadora. And Amadora is makes part of the metropolitan area of Lisbon. It's a suburban area. So I will start sharing my screen. And I brought this topic of aging thinking. So aging thinking is across aging approach. So it highlights the importance of start preparing aging from the scratch, from childhood, from the foundations. And it is also the name of our reference site in Amadora, as Alexia mentioned it. So I will start sharing something about me. So I'm used to introduce myself as someone that is furiously passionate about people. That is how I came to describe myself after reading this sentence on the back cover of a book that really impressed me. From then on, I kept these words as I felt they perfectly expressed my feeling and positioning in relation to the personal and professional fulfillment that I found in supportive relationships. When I was born in 1976, my father was 59 and my mother was 43. We noticed very soon that we would have a short period of time to be physically together. My parents were my superheroes, so they were always giving me their super energy, their super love, and their super protection. By the time they started to be frequently ill, I was not prepared to it. I was not prepared for their incapacity to continue exercising their superpowers, and I felt I was being selfish and that I was increasing their anguish. From then on, 20 years ago, I understood that my personal and professional fulfillment will always be based on supporting people and organizations that are in a challenging situation, either social, financial, cultural, or structural. And I do it side by side, in partnership, building trusting relationships, supporting their empowerment, actively listening to them. And this is why I do what I do. I am the head of innovation at Misericordia of Amadora, which is a charity, providing consultancy, education, and training to people and organizations that need support, trust, systems, process, and tools to overcome challenges and go further. And welcome to Amadora. Amadora, it's the region in Portugal with the highest demographic density. It's 23.8 square kilometers for a population of 175,000 inhabitants. And in here you can see some critical indicators regarding health and also social and demographic indicators. 19% of our population is aged over 65 years old. Of those, 42% are aged over 75, and you can see high rates of death by stroke, for example, of hypertension, of death by ischemic cardiac disease. So we call Amadora as a social laboratory. And this is where my organization operates. We reach daily 6,000 people or clients, if you prefer, based on a workforce of 530 people. We have 4 main core business services, so healthcare, children and youth, vulnerable people, and older adults. On healthcare, we have a medical clinic and a long-term care unit for long-dependent people. And on older adults area, for example, we have 3 nursing homes, 2 daycare centers, and 4 home care support services. And as Alexia was saying, my background is sociology, and the reason for me to share some of my story is because I think the foundations are important on the developing of ourselves. So this is why I brought this more personal approach. And in here you can see some challenges or unmet needs that we have been identifying in Amadora and in the Lisbon region. So, and that is why I brought these oxygen bottles in order to see if we can respond and act directly on these unmet needs. So a lack of opportunity to take a breath. There is a huge overload of information all the time. And there is also, in my opinion, too much stimulation all the time. A social acceptance of fear and failure. There is a huge external pressure to be succeeded nowadays, and everyone wants to be a role model. Then we have this environmental stress. So that is related to the pressure of living, for example, in big cities. The time spent in non-friendly environments such as transports, work offices, public services, and also the anonymization of living in big cities. A culture of instant recognition, the need for immediate feedback, the need for social acceptance, and the pressure of social media based on a more hedonist society, if we want. And finally, an excessively positive society, the devaluation of saying no, and everyone should be smiling all the time. So based on these unmet needs, we created this system, this approach, this co-design approach. So nowadays, we try very hard to really identify what is the problem to address the best solution, not saying we have a solution, what is the problem. So we start to identifying the unmet needs of the people, so making focus groups with our population, try to see what are the most important challenges for them. And based on that, we define the requirements to develop a specific program, a specific solution, a specific approach. And then based on that, we build our use cases and we define our service process models, always with a focus of promoting change management. And this is why I'm not going into detail into this, but just to show you that we have been developing our integrated and person-centered care model. And by integrated, of course, we mean putting together social services, educational services, and healthcare services, working collaboratively and horizontally. And by person-centered, we mean that the organization must be in the periphery and the person must be in the center. And we need to address not only the needs of the people, but also their preferences and their expectations. And this is why in this specific topic that gathers us today, I brought what these such called good practices for us at 3 levels. So individual level, peers or group level, and family level. On the individual level, we have been developing and delivering these soft skill training programs. It was never, in my opinion, so important to stress the importance of the attitude, of the more behavioral competences and skills, because we really need to refine our process of communication in between us. So apart from that, we also have this psychosocial support. And we have been developing these micro entrepreneurship programs. And by entrepreneurship programs, I don't mean necessarily to create our own business, but it's much more about being creative and promoting critical capacity. And then on the peers and group level, we have been focusing on these networking programs. It's very, very important to develop networking skills among young people and even among adults. Then we also have experience in peer mentoring programs, because we know that is much different if we have someone that is a peer of us saying that you should do this with me, we can do it together, you will be able to achieve that specific objective. It's different if it's rather different if it's me, that I'm a sociologist or a non-tech or a technical people saying that to a specific person. And also we have these living labs, so space for creativity and for the people to develop their ideas. Finally, at family level, we have been promoting these family conferences, these parental support groups, and also role playing on how can we best interact together. These are some lessons learned, focusing on the importance of planning, on the approach, on the process, and on change management. It's not rocket science, but for example, in terms of the planning, it's important to be timely, accurate, and 360 degrees approach. And on the approach, it must be challenge-based and person-centered. These are the things that I would like most to highlight. Also in the process, the action research-oriented. So we need to be able to adapt constantly. What are we delivering, the achievements that we have been able to reach, and introduce it in our models, refine our models, interact several times in order to deliver the best solution for the people that we are addressing. And I want to respect time, so this was the things that I would like to share with you today. I'm completely available for any questions. Thank you very much for your attention.
Thank you very much, Adriano, and thank you for giving us your very personal approach to that thematic and also to the work you do in the region. Maybe do we want to take questions now, or do we want to leave them to the end? That meant to the end, Andy. To the end. All right. So thanks very much for leading us into our next block. We wanted to discuss with you the question of what has been working. So more regional examples beyond Adriano's of approaches that that have been shown to be of best practice, for example, or also to take again a regional and therefore different approach, maybe to either other regions or other European countries in this case, and to show us how that has been working. So first of all, to that second block of discussion, I would like to introduce Carsten Modin. I do apologize if I'm mispronouncing your last name. Carsten is Chief Doctor at Rehabilitation Center in Odense in Denmark. Thank you very much for joining today. We're very pleased to have you here. In case you are here, I'm checking again because I know that we had difficulties of reaching out to you, and I don't see you in the list. So we didn't manage to reach out to you. So I do apologize. We were still trying to get Carsten on the phone or on the line into the Zoom call. And so we will directly go towards Dr. Carlos Paulus, who is director at Form Motion in Luxembourg. Carlos, thank you very much for accepting the invitation. I'm also delighted to have you here because I know that you are going to take us to a very different approach, maybe than the ones we've been discussing so far, since you will be talking about consumption, but consumption of some other kind, and therefore also addressing that that switched from consumption to prevention of abuse of substances. Thank you very much, and the floor is yours.
Thank you very much for this nice introduction, and also for inviting me and giving me the opportunity to present you our project. I start sharing my screen. And I will start my talk. So drug checking, there's a mistake. So it's drug checking with a G, and I apologize myself because we have an acronym of our drug checking service, which is DUC. And it's a compression of the drug checking as a harm reduction tool in a very small country, because Luxembourg is a very small country. I will show you in the next slide. Just to have you an idea, you can cross really the whole country in half an hour. There's no problem. If you go by bike, you can take 2 hours, but it's feasible. So we are around 650 residents. I checked the news today, and we will have 32 newborns tomorrow on the list. But it's very small. Luxembourgish is also very defined by the huge amount of diversity. So we have around 170 different nationalities. There are less than half of the people having a Luxembourgish passport, and in Luxembourg City, even we have around 120,000 residents, and you see that 72% are not Luxembourgers. So we are a very small country, and of course bordering Germany, France, and Belgium, which also is important when we are talking about drug consumption and also illegal substances. So I will present you our peer-based project, which is called PIPA Pro, Sex, Drugs, and Rock and Roll. And you see that we have young peers that get a training from us and then go into festivals to do some harm reduction work. It's a peer approach. We are talking about recreational drug use. So for us, we take this term and we stress recreational because all the users that we meet at least are non-problematic drug users, and so that's our point of view. And we do harm reduction with providing information about drugs. So it's fact sheets about effects, but also the legal situation. We promote, we deliver some earplugs because we are in concerts to prevent harm of loud music. We also have condoms to do risk reduction in sexual activities. And if we have summer, we also provide sunscreen for the holidays. Since we began, that's around 10 years, we also have a small survey where we ask our users to autofill a self-report about their earliest consumption. So I will present you here our data that we collected from 2016 and 2018. I didn't include 2019 because I was really short-termed, but basically the reported values are very constant, and I will show you a slide even that the last 10 years were very consistent about the data that we ask for. So we are doing, before the pandemic, we used to cover around 25 events per year. We have the participation rate of our questionnaires about a few thousand. So even we are a small country, this is not a representative survey, but it's only the people that we meet at the festivals. And these are gender balanced. So we have half of it are women who participate and half of it are men. The median age of the people that we met are around 22. So the questionnaire that we ask for are the basic infos about the personal statue, and what it's interesting for us today, it's the recent use of psychoactive the last 2 weeks. So here are the survey, the results of 2018, and you see, of course, alcohol and tobacco are the most consumed substances because they are regulated as all the countries around us. And then the first illegal drug, I think, and that's also European-wide, it's cannabis, and then followed by cocaine, MDMA, amphetamines, and then all the hallucinogens, the LSD, ketamine, psilose, and NPS stands for novel psychoactive substances. These are very rare, so we are really below 1%, and also opiaces, so it's they are very low because we are questionnaring a party population, and these are not very relevant for partying. If we compare men to women, and also this results are very consistent among years. We have alcohol and tobacco, of course, which are the first two, and they are almost balanced between men and women. And then for all the illegal substances, the male participants are always more than the female, and you see the difference between men and women are increasing when the substance is illegal in the country, and also this is consistent among the European countries. So this is only to show you that even this is a non-representative survey, that we are gathering this data for now 10 years, and they are very consistent among the years and among the substances. There are sometimes there is a switch between ecstasy and cocaine, but that is very setting dependent, because as we are not covering all the events that are proposed in Luxembourg, we select often more electronic events, and these are not the common used substances at the events. And cannabis also, we can say that the cannabis use or the cannabis reported use is higher. It's getting higher because of the CBD phenomenon, and this is also common among Europe. It doesn't reflect really an increase of the consumption, but at least it reflected an increase of the reported consumption. So obviously people want to state that they consume cannabis. So in considering drug checking, we began after a pilot in 2016, and we relaunched the service, and we provide a drug checking service in the festivals. So we offer to the user that they give us a sample of their drug, then it is tested in the lab with a GCMS and an HPLC method, and this gives us the exact ingredients of the substance, and then we can provide individual feedback to the user and some harm reduction strategies if the user wants to consume this substance that he gave us for checking. So this is a project which is supported by the National Health Laboratory for the testing part, and it is also granted by the Ministry of Health, because we have an agreement with the Ministry of Health to provide this offer to recreational drug users. Since the pandemic, as you know, as all the most of the country's festivals and clubs were closed, so we started in June 2020 as a direct reaction to the pandemic situation, consultations at our office, so people can take an appointment between 4 and 8 p.m. and they can come to us, provide us a sample of their drug, and then get the feedback at least before the weekend for if they have some going out. So the main objectives of this is to have an inventory, let's say, about substances circulating among Luxembourg for recreational drug users. We contribute to our monitoring system for the NPS, so we are just a small part of it, but at least it's a piece of the puzzle that we can provide. We can enable very fast health alerts directly to the users. We don't do it for the public, but we communicate, of course, our results to the Ministry of Health, and they decide if they are going to make a public alert or not. And of course, because we are very close to the users and to the youngsters, we can enable appropriate governmental health strategies and responses which are very close to the reality of the population that we are talking about. So the players are, as we already told, the National Health Laboratory. Of course, we take the expertise of the Ministry of Health. We get a legal clearance from the general prosecutors because we are handling with illegal substances. So we need special authorizations to do that. We are a privileged contact point for the users. So it's very, as we are a peer-based projects, users don't have this fear of being judged when they come to us, so they speak freely about their consumptions, and we are not judging them. We are just providing them with information, and we see this as a dialogue with users. We also have sensibilization among organizers and societies who are organizing the events, and we have this privileged contacts with the users. So if we have something unusual, we do a Quack Alert. So this is an alert where we don't get direct contact with the users, but we can provide personal feedback. And if the user wants to get it, he receives from us at the moment of leaving the sample a number that he can use to get his feedback. But we are not able to contact the user directly. We do a post on our Facebook and Instagram site we transfer the relevant information to the Ministry of Health, of course, to a national focal point. We are in a network which similar service in other countries. So we are around 20 countries, I will show you a map later, which are doing almost the same work. And since 3 years, we contribute now to the National Drug Report of the EMCDDA with our data that we gathered European-wide. So to the procedure, so you can see that we only collect some milligrams of the substances, so we can't really use it for any other purpose than being tested in the lab. We are characterizing the drugs or the samples, so we take the size, the weight of a pill, for example, and we ask also for the price and where it was by or given. We conduct therefore a semi-directive interview with the users to get a profile about consumption habits and patterns and motivation and effects of the users and the mode of consumption. So we can adopt directly with this information from the user also our work to the reality of the users. So this is just a screenshot of a hidden page where the user introduces his personal code, and then he can download his personal feedback from the sample who was tested. So we got some qualitative results. We had last year we had 120 interviews for the same number of samples being tested, and this last year we had the chance to have depicted 60 samples containing synthetic cannabinoids where the users were not really aware of it, so we could do an alert and react directly with the users. For the MDMA, for the moment, for the last years, the MDMA is that we get for testing is in a very pure form, and most of it are pills, and then we see powders and crystals. Also, since the last 5 years, the cocaine circulating it's very pure, and we have samples who rise up to 70% or more of pure cocaine in a sample. So this is very high or too high for the gathered effects that the users wanted to. So they are complaining, and since ever in Luxembourg, the speed quality it's very aleatory, and sometimes there is no amphetamine in the speed. People are sold of very expensive caffeine. So okay, the discussion we have, so increasingly we are facing the last years very young, unexperienced and unaware users or partygoers. So this is becoming very new. We can't, as we have a small team, we can't gather all the events there are in Luxembourg, so we have to do a selection, and which we started last 2 years ago. One of here is that we offer this during the week consulting opportunities, and we are looking for, I was doing a trainee last year during the pandemic. That was also an opportunity in the lab. So I am now eligible to do the analysis and tests by myself. So the next step is to buy a HPLC, so we can do directly during a consultation the testing of a substance and provide directly in live a feedback to the user. So this is our network. You see that we are implemented in all these different countries, And you see on the right side is the different techniques that are used to do the analysis of the drugs. So I'm not going to go into details because we don't have time for this. We also have a conference that we are organizing once a year. So the last one was in November 2021 in Berlin, and this year I hope, and you see it has already been postponed twice, so we might have a nightlife conference about this work in November 22. And then we have also among our European network, we develop a trip app. So it's a free app. We did this not alone, but we did it with an other European network, which is a network of the Eastern Europe organizations, JUDA, and it was an Erasmus Plus grant that of 2 years that we get to develop this app. So you have on tripapp.org, you have all the information about how to get this app, and also a small video to explain how it works. But basically, you see, if you open the app, you see here on the right a menu, and then you click the menu and you have the pills of MDMA. Here's the example, who were collected and tested in different towns. And then with the map, you can see where the pills were tested, and if you were around Europe, and if you maybe see one of the pills, you can see how the content was, how the test results about this pill were provided. Also, this app includes a part of services. So if you need help, you also can find local addresses of where you are to get some additional information. Thank you very much for your attention. I hope I'm in time. And if you have questions, I will be delighted to have a discussion with you.
Thank you so much. Thank you, Carlos. That was super interesting. It did last a tiny wee bit longer than we thought, but since Carsten couldn't make it, he sent his apologies in the meantime. Actually, it was fine because you introduced us to so many, I'm sure for all of us at some stage or in some respect, new information. I certainly learned a lot. And also in the meantime, we had a very vivid discussion in the chat once you started sharing the stats for Luxembourg. There's been lots of links shared there on the similar stats to be found for EU countries. I particularly enjoyed your final slides as well, showing the cooperation with other types of networks at the European level. So that's really interesting. I don't know, are they? We said at the end, questions at the end, so I'll move over directly to our third session, which is going to be introducing or actually piggybacking on what Carlos just been also presenting, namely the landscape of digital tools for mental health. So some of it, the Trip app that has been introduced at the very end being one of them, but we had invited for this session in particular Ralf Hermanstetter, and I'm very glad to have you here, Ralf. Thank you for joining. You are Head of Counselling and Treatment at Caritas, who will be well known to all European actors since Caritas is obviously active in a number of European countries. You are based in Germany, and yes, you will be telling us about your activities dedicated to substance misuse. The floor is yours. Thank you very much.
Thank you very much. I'm from Munich, and Thank you for the invitation and the opportunity to introduce our app. As you maybe notice, my English is not so good. So I only can offer you some school English and hopefully a nice app. It will be a live presentation and will start. Just a moment. Now, okay, can you see it? Okay, so let's go. Can you see my cursor too? Yes? Okay, here's the cursor, here is the icon of the app. I will open it now for you and we will see what will happen. You can see three parts. One is called info, one is called tracker, and
Okay,
one is called...
Sorry, Ralph, I'm interrupting.
Yes.
We can't see the cursor. We're still seeing the background.
Okay, so maybe you just move your eyes and you will see at the bottom one part is called info. One
no,
part
we don't
no,
see this
you
bit.
Don't see it?
We don't see this bit. We
Okay.
still see the landing. Well, now we can see, yes, the inside.
Yes, now you can see it.
We can see the cursor and we see the inside of the app.
Okay, so a new try. You can see the part called info, you can see the part called tracker, you can see the part called therapy. I will start with the part info, it's this one. The part rechtliches, that means just law and is not that interesting. So I will start with the next one, which is early warning signals. Early warning signals, the one with triangle, you can see it?
We see that, yes.
Yes, I will open it. It's all in Germany, so maybe you have to, okay. We have 6 parts of early warning signals. The first part is the thoughts. And you can, you have some thoughts which maybe are early warning signals, and you can choose one of them or more of them. And let's take this one. You can mark it as an own signal, and it will drop in this part, which is all a summary of your own signals. So you have the feelings is the one with the heart, you have the body reactions, you have behavior, you have general signals, and you have your own signals, which are a consumption of everything you have chosen. Okay. As you can see, we have a quiz. It's here above, a quiz. It's a kind of gamification in the app to bring a little fun in it. And there are 1 question and 4 answers, and 1 answer is completely wrong. 1 answer is right, 1 answer is almost right, and 1 answer is supposed to be funny. So you can choose one of them, and yes, this is a quiz. We have here a part of online consultation of my company. It's not so interesting. You, it's a link. You can get over this link to the online consultation, and you have a part early warning signals. No, not only you have a part emergency.
I'm interrupting, Ralph, because
yes.
we see the notification that for something happened and we don't actually the AirDroid cast is not functioning anymore.
Okay, I'm sorry.
We were seeing everything fine until now. We leave you to it. Fix the problem.
No. You can see it?
We see the home.
Okay, now I stop and try again.
Mhm.
You can see it?
We see the home screen again.
Yes. The home screen, not
But
the app.
not the home screen of your phone, I believe.
No. But now you can see the app?
Nope,
No.
I'm afraid
No.
not.
What happened?
Ah, now we can see the app.
Yeah.
You can see it now?
Yeah.
Yes.
Yes, okay, fine. Okay. I apologize. Okay, so and a part of emergency, so you have one sentence which means I don't want to consume because of whatever fits. What helps me now? How can I distract myself from craving? I leave the situation, which is the most important one. You have part for pictures, which are motivating you in the case of craving, and maybe you are close to consumption. You have the possibility to leave emergency speech, which maybe you can do on your own, or maybe your wife or your your husband or your kid can say something to you. You have the opportunity to have as many numbers as you need to call someone in the case of emergency. Then a hotline for addiction in Munich, but you can use it from everywhere, and the emergency doctor. I think it's doctor. Okay. Now the next thing is a tracker. As you can see, we have three parts. One is craving. The blue one is craving. The green one is the mood, and the red one is consumption. We are going on the green one, mood. As you can see, it's at 50%. And when I do the shift to the left, it becomes gray and the face becomes very sad. And the better the mood becomes, the face becomes more and more happy. And the gray color has a shift to an energetic and very friendly green, and hopefully everybody will get, after a period of time, to a very green mood. Okay, you can have several over the day, and it will have the middle Durchschnitt of it. Here's the part consumption. You can do no consumption, low consumption, middle consumption, high and very high consumption. And here is the craving. You can do the craving from 0 to 100%. And you have the correlations, as you can see, with maybe your craving and your consumption, and of course the mood. Okay. And now the last part is a part of therapy. At the Caritas, we have mostly behavior therapy. So we work a lot with Blackboard, with homework, with flip charts. And the idea is that you have your whole therapy in the pocket and can use it everywhere, and can take whatever you need with you. So here we have some therapy aims. This is aim 1. I did not I did not make any definition of it. So this is aim 1, and I fulfilled it already. We can do another one. We call it ABC. Now we have the ABC, and when I say I reached it. So I reached the whole aim. You will see here at the tracker there is I don't know, funny. There is a sign that shows something. You reach something. Can you see it? Okay. And the same is with maybe you can use photos of the flip chart or of the blackboard. You can do homework, and if you do some photography, so I will make a photography of you now. Now it shows here we have an aim and we have a photography in the tracker. You can see it?
Yep.
Okay, yes. You also can do some homework. You can do some. Yes, let's call it homework. You can call it however you want, and if you fulfill it, it also will appear at the tracker. Now we have 3 photo, and the homework is done. Now you have 3 signs: a picture, homework, and a therapy aim is fulfilled. So that's pretty much it. That's most of it. I could even tell you much more, but I don't want to bother you with my English anymore.
Quite the opposite, but I'm sure there will be a number of questions
Yes.
in the discussion, especially after the speaker coming right after you. I'm sure there will be joint question addressed to both of you that will be on probably the number of users and the feedback you received and those kinds of things. So in order to let that discussion happen, I would really like actually to link over to Christine, who is project manager at Blue Prevent, and who will now be sharing another German solution, another German app that's been put in place some time ago. Christine, thank you very much for being with us and for bearing till the end of this webinar or ecosystem gathering to introduce you to introduce us to Blue Prevent. And the floor is yours. Thank you.
So, good afternoon. You can hear me?
We can hear and see the presentation just fine. Thank you.
Perfect. Okay. So, okay, let's start. Okay. Yeah, my name is Christine Hesse. I'm not the project manager, but I'm part of or a member of Blue Prevent. Blue Prevent is a project of the German Blue Cross, and yeah, which offers youths and young adults an innovative, lasting, and double-tracking addiction prevention. You can use it online and also in presence by using our modular interactive program. Yeah, Blue Prevent meets young people at eye level with their wishes, dreams, fears, pressures, and so on. And so there's our claim, temptation seeks limits. And yeah, the background is from time to time, all humans need thrilling experiences like the win of one's team, climbing, diving, parkour, roller coaster rides, bungee jumping, or falling in love. And that's also possible without the typical addictive substances such as alcohol, nicotine, cannabis, or other drugs. And yeah, because every behavior can turn into an addiction behavior if there are hardly other alternatives anymore. And Blue Prevent offers young people a perspective of mainly using lots of resources in their lives and evaluating the risk of their behavior healthily. Okay, therefore Benjamin Becker, the head of Blue Prevent, the project manager, developed Blue app in 2015 as a coach for the trouser pocket, like the Carried app. And you can download onto your smartphone if you don't did or didn't it ever. And so you can follow me at the next steps. Okay, Blue app is in its first revised edition with a blue bot. He says hello to the users and asks for their nicknames in a very friendly way. And if they want, Blue bot accompanies them through the 11 subject areas on smoking, cannabis, drugs, alcohol, having parties, gaming, social media, pornography, school pressure, bullying, and family trouble. And there you find FAQ answers, consumption checks, 5 helpful steps how to deal with difficult situations, video clips, as well as links to the Blue chat, counseling centers at your hometown or other digital addiction offers. Genau. And Blue app has been downloaded 25,700 times by now. Okay, Blue chat is available for an hour in the afternoon every weekday and attended by trained coaches. There are about 800 dialogues a year. Young users increasingly make cannabis, gaming, the fear of missing out, addictive relatives, smoking cessation, pornography, bullying, and family trouble the subjects of discussion. Now I show you our teaser by translating the statements at the same time. If addiction control you and you don't know how to handle it, there's an app to take care of you. Always with you, anonymous chat. Share your experiences with coaches. Check your consumption. Counseling centers near you. Receipts for non-alcoholic cocktails. Get information about addictions and drugs. Keep control. Declare war on addiction and become the best version of yourself. Okay. Just a moment.
while you are looking for the next screen to share, Christine.
Yes.
Just to let you know, I mean, I'm very impressed that you managed to share the sound of that video, because this is something that I usually fail at. However, the music was quite loud, so we could hear what you were translating, but the music was a bit loud, well, maybe just on my device. Maybe for next time, but it was I really appreciated that visual campaign. So ready when you are.
Okay. Es ist weg, hier ist es. Where is the screen? Oh, no.
Maybe because we are running a little behind time, Christine, could I maybe then invite Andy to lead us into the discussion part?
Yeah, okay. Okay, sorry.
That's no problem. Listen, first thing, these things happen, okay? Yeah. And we'll share the rest of your slides with the recording. So I've lost count of the amount of slides I've lost in the past, so panic not.
No,
it's really good to see that being demonstrated.
Okay.
What I'd like to say is, firstly, thank you to all our speakers. I think we've seen a rich diversity there with all the inputs. I've got a question for, and I don't know who wants to come in on this. Is we've seen a lot of services, obviously, for young people. I'm going to be slightly provocative because I can. And be a complete surprise for some of you. What about the rest of us who maybe would think about some of these apps as being very youth focused, some of these services being very youth focused? What about the rest of the population? Because certainly I know that the addictive service or addiction services in many countries are always targeting young people for obvious reasons, but then fail to miss some of the more addictive behavior amongst older adults. Okay. And then second question, okay. What do you do with people who've got a dual diagnosis? So they've got an enduring mental health problem and an addiction. Does that mean your service has to stop or collaborate with other service providers? So what about the rest of us? And then what about a dual diagnosis? Any input from colleagues? Thinking perhaps Maria from the ministry. I don't know if you've got any input from your side of things, or even from Luxembourg and Portugal as well.
If you're interested, I'm gonna send you some links. For example, the tobacco campaign and the alcohol campaign are addressing adults mostly, not youth. And for example, we have lots of information brochures focusing on elderly people. So, and also the gambling behavior. It's not the problem of the youth. So yeah, if you're interested, I can send just check like a list or anything.
Because it's often missed, and I think it's we've seen some great services here.
If I may jump in on that, because we had a discussion prior to, when we were putting the agenda together with one of our members, who is Dr. Rohrbach from a clinic in Cologne, and she was saying that she had actually great trouble. So her usual patients, it's a walk-in clinic, and her usual patients are mostly concerned with excessive drug consumption or excessive alcohol consumption. But obviously they also are in that particular group of patients that she receives and treats, they also do have already existing mental health issues. So there's a combination, and very often they also do live on the street. They're homeless or in between care homes and in between settings. And so she says it's so difficult for her to treat them adequately, because also out of reimbursement measures, as a doctor, she would know how to address that multiple problem, but very often she doesn't. She really can't, she can only address one problem at a time because of the system that is in. So, and she finds it very difficult, even though she knows, even the patient, because they are recurrent patients coming back. And so she says it's it saddens her, because she's very often she can only treat them either for the excessive use of substance, or the other time for the ongoing chronic mental health difficulties that they do have. And so there's a structural problem here, most definitely. Yeah.
I think certainly historically, traditionally, when you used to see the label of a dual diagnosis, you know that the psychiatric services have shown the people the door, because they've said this is someone else's problem, or vice versa. So it's over to the alcohol people, or it's over to the mental health people. And I'm not sure if that's changed much. Interested to hear from Luxembourg and also from Portugal.
Yes. For the first question, I think it's important to stress out that we distinguish between substance use, what we call recreational use, and misuse, which is in the title of our conference. So for us, the use of a psychoactive substance, it's not problematic per se, our population are youngsters, but mostly young adults that can afford their decision to use substances, and we respect that. So we are not judging them, and we are not preventing them we're not preventing them about the use. We are preventing about harm associated to their use. So that's very different about, let's say, a more generalist approach that the BZGA has in Germany, because they are also addressing their messages to other populations, which it's very different. And then secondly, I think according to this point, it's very useful to compare the legal situations in the different countries. In Luxembourg, for instance, if we take alcohol or tobacco, let's take alcohol because everybody knows what we're talking about. In Luxembourg, the regulation of alcohol is about forbidding the sale of alcohol to minors under 16 years old. So the use of alcohol, it's not regulated in Luxembourg. It's not like in Germany, where you also have the use of alcohol, which is regulated, and you have these differences between 16 of age for beers and wines, and then you have 18 years for the other types of alcohol. So it's very different. It's a different approach also on the legal system. And that's how we handle these issues, and also the consumptions or the use of other drugs who are not regulated. Okay. So of course, we also communicate to the users that they are that they have to take in account, for example, legal risks because they are using illegal drugs. And they have to be aware about this. But we will never influence them about taking their own decision. We encourage the people to be responsible about their decisions, and also about the consequences of their decision behavior.
Okay.
That's in short,
Okay.
but it's an important difference. And to the other question, we are not confronted to double diagnose, but if we encounter people in our service who are at the border of a recreational use and getting into a problematic use behavior pattern, then we will stop our follow-up with this person, and we will explain why we are stopping our work, because our service is not appropriated, because we think that the person is getting into a pathological behavior, and then we will, if the person agrees, we will contact a specialized service and organize a takeover for this person.
Okay, that's helpful. That's helpful.
Yeah.
Just conscious with time now. Portugal, obviously you've got a slight difference in terms of drug policy legally. I can remember the difference in drinks policy in Germany as a younger boy years ago. But in Portugal, obviously there's differences in terms of drug legislation. What's the picture there?
Andy, do you want me to respond directly to your to the questions that you posed, or
you choose?
Okay, yeah. So I totally agree with you. So the presentation is more focused on young people, but as I mentioned in the beginning, so in my organization we have this cross-aging approach. So we tackle all the different ages, and what we do is because I mentioned also that is to address the needs of the different groups in a more effective way. So this means that we have different strategies according to the different ages, but we tackle all the different ages. So young people, adults, and also older adults in the different approaches that we follow. And in what concerns your second question, and that is also something that I try to highlight in my presentation, it's the importance of collaboration, both at an internal level and also external level. So internal level, we have been promoting this change management approach, so bringing the different areas to work more collaboratively and to define integrated approaches. So this is why integrated care is so important to us. Having said that, we also have this vision of working collaboratively with all the most relevant stakeholders that we have in Amadora, and of course also outside, at a regional and a national level. So if we found something that it is not our area of specialization, we don't want to be a specialist in everything. So we find the right partners to work together, and to the only thing that we want to ensure is that the same client, the same people don't have to tell his or her story several times again. So this is the effort that we need to pass to the organizations that are providing services in order to avoid these repetition problem and confidentiality problems. So in order to make decisions more quicker and more informed, that is the importance of collaboration. I don't know if I responded to your question, but that is why we try to do.
Very helpful, very helpful. And I think I'm conscious of time. The need for collaboration is one that I think is paramount in psychiatric work, and we forget that message at our peril. We still seem to work in silos a little bit in the field of mental health, specifically with contact with alcohol and drug services, let alone gambling and pornography and other addictive behaviours. I'm just conscious of time. I'd like to personally thank all the speakers from today. I think we've seen some great input from Portugal, from Germany, sadly not from Denmark, but we'll catch up with them later, and also from Luxembourg. I'd like to thank the speakers for their time and their input and their work they put into this. We will follow up and share videos, obviously, with the people who've registered for this didn't turn up today, but they usually watch this on catch-up TV. And we'll share, as long as people are okay, the resources that have been shared today, the videos, the presentations, etc., as well as those extra resources, because those are vital, because that helps us to break down some of those silos between countries and look for collaboration. That collaboration will continue in the next of these thematic ecosystems, where we're going to target a slightly different area in the mental health sphere. And that's that to do with what we're doing today, working from a screen, working from not so much an office, and the stress and anxiety and other mental health problems that have come about because of the changing work environments, not just because of the pandemic. So if you're interested in that, and that topic around, as we sort of say here, digital work, remote working, working from home, sat on a laptop on your bed, and come along to that session. We'll be advertising that shortly, and we'll be welcoming any input from people who've got both need and solution in that area. But again, thanks to our speakers. Your input has been very, very valuable. Thanks obviously to Maria, to Ralph, to Adriano and to Christine. It's been brilliant to listen to you. I personally have to thank also Alexia and colleagues for help bring this together. Carlos, your input from Luxembourg, which is just really, really helpful. How you managed to hold demonstrating that. I've tried that. It's really, really hard, Ralph. So well done. Thank you for that. And a very useful app, and I think timely to showcase that. That, as far as I'm concerned, will wrap up our call for today. Thank you very much for your time. We'll speak to you soon.
Many, many thanks to everyone. Since the last thing, since the slides will be shared, you also have the emails of the speakers whenever they are in those slides. Feel free to contact us at the Health Region Cologne-Bonn, or Andy or Adriana at the ECH Alliance if you'd wish to receive more information or more contact on that topic. And I'm very much looking forward to seeing you all in a couple of months, or maybe 3-4 months for the next session. Thanks very much.
Thank you.
Thank you.
Bye-bye.
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 Thanks.